Hello everyone, this is Dr. Naz. Welcome to my YouTube channel. Today I'll be discussing about Varicella zoster virus. Varicella zoster virus belongs to herpes virus family, which is a DNA enveloped virus, and the human is the only reservoir of this virus. It is a dermotropic and neurotropic virus, that is, it involves the skin and nervous system. It produces two distinct types of diseases. The primary infection is chickenpox, which is acute and highly contagious disease. Then in 10 to 20% of individuals, this virus becomes latent in neural ganglion and get reactivated after the age of 50 years or when the patient is immunocompromised, and it causes shingles or herpes zoster. So first we will discuss chickenpox, which usually occurs in children. Virus is transmitted from one person to another via respiratory secretions or direct contact. The incubation period of this virus is 11 to 20 days, after which vesicular eruption begins. The infectivity period is 4 days before the rash appears until the last vesicle crust over, so it has a long infectivity period. As I told you before, after incubation period, a vesicular rash appears, which is also known as teardrop or dew on rose petal rash because it looks like a teardrop. This vesicular rash is centripetal in distribution, that is more towards the center than on the periphery. It means it's more on the trunk than on the limbs. It is intensely itchy rash, and it progresses from small pink macule to vesicles. Vesicles, what is vesicle? Vesicle is a fluid-filled blister, and pustules, which is a pus-filled blister, within 24 hours. So within 24 hours, it will progress from a pink macule to vesicle and pustule. New crop occurs every 2 to 4 days, and each crop is associated with fever. It means that every 2 to 4 days, the fever will also occur. In this picture, you can visualize different varieties of chickenpox rash. The first one is teardrop, second is a small macule, which is red in color, red to pink, and the third one is vesicle, fluid filled, and the fourth one is pustule, which then crust over and then new crop may begin. Complications may include secondary or superimposed bacterial infection that occurs from scratching, which is the most common complication, pneumonitis, mostly in smokers, and it can be fatal, hepatitis, and encephalitis. Encephalitis is self-limiting, and cerebral ataxia can occur, but it is rare. Maternal infection in early pregnancy can cause developmental abnormalities of eye, CNS, and limbs. Maternal infection within 5 days of delivery leads to severe neonatal varicella with visceral involvement and hemorrhage. So diagnosis is mainly clinical by rash, detection of antigen via direct immunofluorescent, and PCR of aspirated vesicular fluid can be done if there is a suspicion. The management options include antiviral agents, Varicella zoster immunoglobulins, and obviously then prevention from the disease in other individuals. So what are the indications of antiviral agents? A patient who presents within 24 to 48 hours after the onset of vesicles but has uncomplicated chickenpox. A patient with complicated chickenpox regardless of duration of vesicles. An immunocompromised host regardless of duration of vesicles. Immunocompromised means patient with diabetes, HIV, etc. Pregnant women regardless of duration of vesicle. So in uncomplicated chickenpox within 24 to 48 hours of vesicle, complicated chickenpox, immunocompromised host, and pregnant women, they will receive antiviral agents. So antiviral can be given either orally or intravenously. Indications of oral form includes adult, immunocompetent, and children. And in IV form, if the patient is immunocompromised or pregnant woman, it means if the patient is immune competent and adult and children, then you will give oral form. And if the patient is immunocompromised or she is a pregnant woman, then you will give it in intravenous form. Oral form includes two drugs, acyclovir and famciclovir. Acyclovir dose is 800 mg 5 times a day, and famciclovir includes 500 mg 3 times a day, and it is given for 5 days. IV antiviral until patient is improving, then switch to oral form until all lesions crossed over. So immunoglobulin is ideally given within 7 days of exposure, not infection. So if you get exposed from a patient suffering from chickenpox, so within 7 days of that exposure, you can get immunoglobulin. It may attenuate disease if given up to 10 days afterwards. It is indicated in the following conditions. Number 1, those with significant contact. And what does it mean by significant contact? You are sharing a room for more than 15 minutes, face-to-face contact with the diseased individual, intimate contact with person with shingles, hospital contact with chickenpox, that is a patient, visitor or healthcare worker. Number 2, susceptible host, that is individual with no history of chickenpox. Third, pregnant woman at any stage. Fourth, immunocompromised individual, example acute leukemia, HIV, organ transplantation, high dose of steroids. So these all patients will be given immunoglobulins. Newborn is another indication of immunoglobulin. So if a baby is premature infant, that is born less than 28 weeks, or a newborn whose mother develops chickenpox within 5 days or before or 2 days after delivery, so you will give immunoglobulin to that newborn as well. Vaccine against Varicella zoster virus is a live attenuated vaccine, so you are not going to give it to pregnant women or immunocompromised individuals. Children receive 1 dose after 1 year of age and a second dose at 4 to 6 years of age. Adults receive 2 doses at least 1 month apart. Now we will discuss about shingles, which is caused due to reactivation of the virus. This is, we have already discussed that when Varicella zoster virus after primary infection becomes dormant in dorsal root ganglion of sensory nerves and then reactivated later in life, and it is reactivated especially in immunocompromised individual and elderly individual. So if there is recurrence of this virus, then it means there can be immunodeficiency. It is more common in elderly and it presents with a rash that is classically unilateral. This point is important, that the rash is unilateral and it is distributed to the dermatomal region. The onset of rash is preceded by severe dermatomal pain. It means the patient will complain of extreme burning discomfort in the affected dermatome, and after 3 to 4 days of this pain, discrete vesicles may appear and there will be a period of brief viremia. Occasionally there is paresthesia without rash and it is called zoster sign herpetic. The most commonly involved dermatome is thoracic dermatome. However, ophthalmic division of trigeminal nerve is also frequently involved, and when this ophthalmic division is involved, it can lead to corneal ulceration, blindness, and another complication which is called granulomatous cerebral angiitis, which is a cerebrovascular complication that can lead to stroke-like syndrome, especially when ophthalmic division is involved. Ramsay syndrome is another complication of shingles. It occurs when the virus involves the geniculate ganglion. Geniculate ganglion is the sensory ganglion of facial nerve. It presents with facial palsy, ipsilateral loss of taste and buccal ulceration, as well as vesicular rash in the external auditory canal. Another complication is post-herpetic neuralgia. It is the most common complication of shingles. What happens in it, that after the healing of rash, the pain persists for approximately 1 to 6 months. Treatment involves analgesia as well as therapy with acyclovir or antiviral agents. It reduces both early and late onset pain, and it is very effective in the individuals who are more than 65 years of age. And for post-herpetic neuralgia, gabapentin or amitriptyline can be added to minimize the pain severity. If you have any query regarding Varicella zoster virus, you can ask me in the comment section. Please like my video and subscribe to my YouTube channel. Thank you.